Mi dispiace, ma io devo continuare in inglese perché il mio italiano non è così buono per fare tutta la presentazione. Well, this is the topic for today. It's something related about urgency. Urgency means to act quickly for some reasons. These are my disclosures. And the topics I will touch upon this afternoon is about the patient after a fracture, the concept of imminent risk of fracture, and a couple of words about treatment strategy. The patient after these fractures we see every day in our clinical practice has a series of problems that we all face. Pain. Pain is one of the most prominent problems, and pain induces a series of problems, reduces mobility, impairs this reduced mobility, impairs balance and equilibrium, and there is also a quite fast, in particular in this elderly frail patient with fractures, a rapid loss of muscle strength with weakening and atrophy of the muscular system. And also we use pain drugs. They usually make worse this balance, and the final result of all these components is an increased propensity for falling. But talking about the bone in patients with a fracture, we know that there is also an increase in the fragility of this bone because there is a status of high remodeling, a weakening of the structure, and acceleration of bone loss with the final result of a reduction in bone strength. This occurs both at a cortical level, where there is an increase in porosity and remodeling and a decrease in the mechanical strength of the cortex, as well as in the trabecular bone, where there is an increase in the resorption cavities. These resorption cavities create stress risers, weak points, where the mechanical performance of the bone is dramatically reduced. And we know from several mechanical studies that a decrease in bone mass is resulting in a quite important reduction in the strength of the bone, that in case of adding resorption cavities to the structure, this reduction is being only a 20% decrease in bone mass is up to 50% in the strength impairment. This drives us to the concept of imminent risk of fracture. What is an imminent risk of fracture? This is an imminent risk of fracture. This is an individual that will break a bone very soon, but when we talk about our clinics and our patients, we are talking about not so imminent risk. We are foreseeing the risk in a time frame of 1 to 2, maybe up to 3 years in the coming months. They are already classical, all data by Bob Lindsay, showing that in postmenopausal women that have sustained a vertebral fracture, the risk of having another vertebral fracture within 1 year is 20%. 1 out of 5 women will have another vertebral fracture in the following 12 months. And this risk increases dramatically if they are more than 1 or 2 or more prevalent vertebral fractures, showing that the weakening of the bone that is reflected by the fracture is a good marker of extremely increased fragility of that bone at the short term. These data come from the GLOW study, a multinational study we performed a few years ago with more than 50,000 postmenopausal women, and we address also this fact of the risk factors for having a fracture after 2 years of follow-up in this cohort of postmenopausal women. Again, having at baseline 1, 2, or 3 or more fractures increases very much the risk of sustaining another fracture in the following 2 years, up to 25% of women with 3 or more fractures will have another fracture in the following 2 years. And this risk is attributable to all kind of fractures, more so in patients that had a prior vertebral fracture, but also having had a hip fracture, a pelvis, an upper leg, or a rib fracture also imputes an increased risk of having another fracture in the following 2 years. But more recently, in this large population-based cohort study, Elina Johansson and John Keynes published this time relationship between the increase in risk and the time that has transcurred after the incident fracture until the sentinel or indicative fractures. And you see that in the first 2 years after a fracture, the risk increases tremendously, and thereafter levels off, and the increase of risk is not so exaggerated, but still, with respect to the control population in the dashed line below, is still higher in the 10-year follow-up period in this particular study. And this accounts for all the fractures for hip, for spine, for forearm, and for humerus fractures. In all these fractures, there is an increase incidence that is more accentuated in the first 1 to 2 years, and then decreases or attenuates a little bit in the following years. And the hazard ratio is applicable also to all the fractures. So having a hip, a spine, a forearm, or a humerus fractures is a good indicator that in the near future the patient is at a very increased risk of another fracture. And this is independent of age for all the fractures, spine, pelvis, clavicle, humerus, etc. And for ages between 65 and 74, 75 to 84 and above 85, there is a substantial increase of having another fracture 1 year after the sentinel, the so-called sentinel fracture. In this other recent publication, there is also a same observation in this cohort study showing that there is an increased risk in having a subsequent fracture after an incident fracture for all the fractures, but again, for the vertebral fractures is where the rates of increase in the risk are more pronounced. There are several reasons for this imminent fracture risk after having sustained a fracture. We know that there is an increased rate of falls during the rehabilitation. There is a decrease in the coordination of the patients. We talk about the loss of trabecular and cortical bone, and therefore the deterioration in bone strength, the increase in the frailty of the patient after a surgical procedure, and indeed the underlying diseases and other chronic conditions that are very common in these patients. In fact, if we look at all the factors that finally are acting on the propensity and the occurrence of a fracture, we know that after having a fracture, there is an element of falls, remodeling, nutrition, bone mass, reflexes, and bone strength, all them working together in increasing in these first 1, 2 to 3 years after a fracture, increasing the risk of having another fracture. What are the risk factors that have been identified for having an imminent fracture? This is another study based on the large population of US claims data, and having had previous falls, being older, having a bad health status, and some specific comorbidities, psychosis, Alzheimer's disease, neurological conditions, or other factors like wheelchair use, use of medications that are psychoactive, impairment in mobility, all of them are good predictors of having an imminent fracture. And this is the table for this paper, where we see that the strongest predictor of having an imminent fracture is having a history of falls. This was already identified again in the large GLOW study, where the risk of having fractures, incident fractures, in a 3 years follow-up was very much increased in women having neurological, gastrointestinal, rheumatological, respiratory diseases, malignancy, or cardiovascular problems. And also in patients with chronic obstructive pulmonary disease, there is an increase in the incidence of vertebral fractures, both at 1 year on the left and at 3 years. And this increase was more pronounced if this patient already had a prevalent fracture at the beginning of this follow-up period. And again, the number of prevalent fractures was also a good predictor of having a very increased risk of new fractures at the short term. Another factor that was identified also in the GLOW was the loss of weight, unintentional weight loss, where they was seen that after 500 or 1,000 days of follow-up in a 1.5 to 3 years approximately, there was an increased risk in hip and in spine fractures in these individuals that have been losing weight. What is the treatment strategy in this situation? This topic will be enough for several lectures, so I will simply suggest a couple of points. The goal is to reduce as fast as you can the risk of new fractures. And for that, we can use two types of strategies, non-pharmacological and drugs. The non-pharmacological are quite obvious. We have to minimize the risk of falls, improve nutrition, reduce the polypharmacy, treat pain, frailty, comorbidities, etc. And with respect to the drugs, we need drugs that are rapid, potent, and injected. Why? Rapid, because the risk is imminent, so we need a rapid onset in the therapeutic effect. Potent, because the risk is very high, so we have to use the most potent drugs we have in our armamentarium. And injected for a couple of reasons. The treatment, when we inject a drug, is fully dosed. The anti-fracture efficacy in all the trials that have been published is higher than the oral drugs, and the onset of effect is possibly faster. What are the conclusions we can take from this review? Imminent risk requires immediate action. A recent fracture, importantly, perhaps more for vertebral fracture, and some clinical factors identify the patient at an imminent risk of having a fracture. And we need to treat the bone fragility, but also the whole patient, because the next fracture could be the last one for that particular patient. And with this picture of my hospital here in Barcelona by the beach, and our patients receiving high doses of vitamin D, I would like to thank you for your attention.